Hi everyone, this is ABC's Anesthesia, and today another episode of this final exam practice. So we're doing Viva 4 of the 2025 first sitting paper. And hey, Elle, we've got you back from the days when you were a star on the interview type stuff. And I think you wouldn't believe how many people had watched that video and said, hey, yeah, Elle was really good. And a lot from her. Where are you at now, Elle?
So I am about to sit my exam in 3 weeks. I'm currently at the Gold Coast and still a long-term devout enthusiast fan of the ABC Anesthesia channel.
Yeah, that's what I paid you to say. So that's great. How's the exam practice going at the moment?
I've been good. The department's really supportive and I get lots of Vivas in. I think I keep getting told I talk too much. So you will be able to see whether or not I chat too much. So I think my goal is to try and have structure for most questions and to not be anxious if I get a question that I don't know in detail. I think that's my biggest anxiety is I don't know something in the nth amount of detail. So you can watch me come undone if that happens.
Absolutely, and but that'll be fine because whichever way we go, it'll be like a good learning point anyway for everyone who's listening, and hopefully for you as well. Because it's almost like you want to be in those positions so that you get to practice what it's like to be under that kind of having that issue in your head of like, oh shit, do I know enough detail or not? Mm-hmm. Let's crack on. So this is the Viva STEM again from the 2025 first sitting paper. It's like really long, which is always annoying. So that's 2 minutes. I'll start reading for anyone who's just listening to this on the podcast. You're an anaesthetist in the emergency theatre at a tertiary hospital. Your first case is a planned open right inguinal hernia repair in a 73-year-old man who presented overnight with an incarcerated hernia. Conservative management has failed. The surgeon wishes to proceed urgently to prevent strangulation. The medical history: severe smoking related COPD with type 2 respiratory failure. The ABG on room air, pH 7.32, CO2 49, PO2 81, bicarb 29. Coronary artery disease as well as past history: right coronary artery 80% stenosis, valvular heart disease, severe MR, severe TR, normal left ventricular ejection fraction, mild right ventricular systolic dysfunction. Pulmonary hypertension with an RVSP of 60 millimeters mercury, paroxysmal AF, stage 2 chronic kidney disease with a GFR of 65 mils per minute, creatinine of 100 micromoles per liter. Medications are amiodarone, digoxin, furosemide, metoprolol, rivaroxaban, rosuvastatin, and tiotropium inhaler. The question is, what are the key issues in formulating your perioperative management plan for this patient? Yeah, Elle, that's about 2 minutes. So just to repeat the question, what are the issues in formulating your perioperative management plan for this patient?
So this is an elderly patient with multiple comorbidities presenting for emergency abdominal surgery, secondary to an incarcerated hernia, likely with small bowel obstruction at a tertiary centre. My major concerns can be divided into patient, pathology, anaesthetic, and surgical concerns. So my patient concerns is that this is a significantly comorbid patient with severe COPD on only a single inhaler therapy, despite currently being in a type 2 respiratory failure. This patient's got severe MR with associated moderate pulmonary hypertension and AF with rate, rhythm, and anticoagulation. Also has severe coronary artery disease and, curiously, is not on any antiplatelet therapy despite this. I would evaluate the severity and the stability of this patient's disease in the setting of an acute insult based on history, functional capacity, vitals, examination, and investigations in a time-sensitive fashion with particular attention to opportunities to optimize as well as risk stratification so that this patient has fully informed consent. On that note, this patient is elderly. I would review if there's any advanced healthcare directives available to discuss with the patient and ensure I have fully informed consent. In terms of the pathology, I want to know what the time course as well as management to date has been, in particular, whether or not there's been decompression with an NG tube, antibiotics, and whether there's any evidence of hypovolemic or septic shock. In terms of the anaesthetic, I'll be reviewing any contraindications to a neuraxial in this patient, noting he is on an anticoagulant. And I also would be discussing with the surgeons if they have any concerns of the likelihood of this converting to a laparotomy.
Yeah, good. Tell me about your assessment of, you mentioned severity and stability of disease, of the COPD, and any other particular, the most important pathologies there.
Yes. So this patient is has multiple comorbidities. I would be focusing my history and examination investigations, particularly on his cardiovascular and respiratory status. So on history, in particular with a COPD, I would like to know, first of all, when it was diagnosed, the name of his respiratory physician and whether I have access to any letters. I note that the etiology is secondary to smoking. Is he still a smoker? I want to know whether or not he's on home oxygen, whether or not he has exercise limitations. Can he leave the house? Is he short of breath at rest? And I would also like to know if he's ever previously required NIV or intubation and ventilation in hospital. Does he have any recurrent infections? Does he have a current chest infection now? And does he feel symptomatically that his COPD is worse than normal? Shortness of breath? Is he got any respiratory distress? In terms of his cardiovascular history that I would like, again, in particular to his severe MR, I would like to know whether it's primary or secondary. So is this secondary to a structural disease process or whether it's secondary to a cardiomyopathy or an ischemic process in the past? Again, I'd like to know the name of his cardiologist and I'd like to access those letters. I would like to know if he previously has had decompensated heart failure with admission to hospital with APO or requiring any circulatory support. I would like to know his current status in terms of whether he describes any chest pain, syncope, shortness of breath, or notices any peripheral edema. And the same screening history I would apply to ischemic heart disease. In terms of the other key features on history I'd like to know for this man, he's elderly. So I would like to get a social history, his activities of daily living and what his supports are like at home, whether he has hearing aids or any issues with his sight.
Let's move on. So what would be your, how would you organize your anesthetic plan for this patient?
So my anesthetic plan, as discussed earlier, is taking into consideration the severe comorbidities of this patient. My ideal plan would be a spinal without sedation with an arterial line and 2 white wall access. I would need to review contraindications for a spinal in this instance and, of course, ensure that the patient is happy with this plan. So first of all, I would like to know whether he's in florid septic shock. So I'd want to gas and assess him from that point of view.
And you mentioned in the history, you mentioned that he's on rivaroxaban.
Yeah.
But not on an antiplatelet. He hasn't omitted that dose. What do you think of that?
So I would just like to clarify specifically the last time he took the dose. So if
today is the afternoon or early evening this morning.
Okay. So given the high risk nature of this, I would be consulting with my hematology team at this point in time to see if there's any opportunity to immediately reverse the effects of rivaroxaban or do a formal DOAC assay or anti-10 assay just to check the levels, as this would be the safest option for this patient.
Yeah, good. Let's say that they say it just wouldn't be safe to reverse or they don't have the reversal agent. What is that reversal agent called?
Adenafac. Sorry, we don't have it. So that's why I sound a bit silly saying the name, but it's Adenaxa, I think. But Prothrombin is what we would use in our institution.
Yeah, excellent. Good. So Anexa or Xanet, which again, we don't have in our institution as far as I can tell as well. So let's say you are unable to reverse this. What's your plan and how do you, how would you translate for this?
Okay. So first of all, I'd optimize this patient. I would optimize him. And then given in a time-sensitive fashion, this requires an MDT approach. Specifically, I would like the involvement of the surgical team. This patient clearly is going to have an HDU destination, so I want to notify ICU early on. I'm in a tertiary centre, so I would like advice from my cardiac anaesthetic colleagues and or cardiology, in particular for the safest way to induce this patient. But my overall plan for this patient would be competing. This is a an anaesthetic with competing interests, in that this patient has potentially a small bowel obstruction with a significant aspiration risk, however, has a significant risk of respiratory and cardiovascular collapse on induction. So my plan would be to ensure that there's an NG tube in situ prior to induction of anesthesia with decompression. I would do a GA RSI with propofol sparing technique, specifically with, for this patient, I'd probably give 2 milligrams of midazolam, 0.5 milligrams per kilo of ketamine, 100 mics of fentanyl, and 1.2 milligrams per kilo of rocuronium with a size 8 endotracheal tube. In terms of the monitoring that I would like for this patient, at a minimum 2 wide bore access and an arterial line, I think there's a risk-benefit assessment in terms of central line placement for this gentleman. And certainly if I have time, I would like to place the central line for him prior to induction, and awake central line. And then standard ANSCA monitoring applied, with particular request for BIS monitoring, NMT, and a temp probe.
Yeah, good. So that seems like a reasonable plan. Is there any other options for anesthetic besides neuraxial and general anesthetic?
Yes, you can do a ilioinguinal and iliohypogastric and genitofemoral nerve block. But given that this involves likely ischemic viscera, I don't think that would cover the visceral component. Although I could discuss this with a regional expert at my hospital to get further advice.
Yeah, let's say you they said you could do this case with a field block, but what would be the problem to do it? What would be the issue in this case?
So the issue, in my mind, is that there's a significant visceral component contributing to the pain in this, and I don't think that an inguinal field block would necessarily cover that. It's more cutaneous coverage. And then I think, secondly, my concerns are the likelihood of whether or not this patient would be converting to a laparotomy, I suppose.
Yeah, no, and that's fair. So, good. So let's say you do the anesthetic, you do the induction, everything seems pretty reasonable, but then suddenly during the case, the blood pressure drops. You're maintaining it on, say, an infusion of NORAD at 5 to 10 mics per minute. The blood pressure is about 100, 110, and suddenly drops to a blood pressure of 70. And the saturations kind of trend down as well to about from 96 down to 92. What do you do?
And sorry, just to clarify, is this patient awake or intubated? Sorry, I missed that.
They are intubated with your general anesthesia plan, as you said.
Well, that was the problem, isn't it? All right. So, so this patient is, this is an evolving emergency situation. I would confirm this emergency by scanning my monitors with particular attention to my end-tidal CO2 trace and my arterial line. I would scan the patient's color, pulse, double-check the position of my airway and auscultate the chest, and I would scan the surgical field at this point in time. Once I have confirmed that this is indeed emergency, I would temporize with 100% FiO2, increasing my flows. At this point in time, I would open my fluid line, turn down my PEEP, increase my vasopressors if I have any running, and give boluses of metaraminol. My differentials at this point, specific to this patient and specific to the surgery, would be cardiogenic shock in the setting of his known AF and potential arrhythmia, as well as either LV or RV failure, as well as potential hypovolemic shock in the setting of bleeding, depending on where we are in the surgery. Obstructive shock would be less likely in this setting, and distributive in the setting of potential sepsis or anaphylaxis.
In the context of having the past history that you mentioned with all the valve problems, the RVSP, which was
60.
Yep. What is, how would you mentioned RV failure, how would you diagnose, how would you diagnose that?
So I would have a high index of suspicion for RV failure in this patient. I would diagnose this based on clinical features as well as echographic features Clinical features in the intubated patient can be difficult to ascertain, but certainly a marked elevated JVP or a new tricuspid murmur would suggest to me.
You're going to have trouble with the JVP just because it's an intubated patient. What else?
I would immediately request a transthoracic echo, and specifically the features I would be looking on my transthoracic echo, I would divide into structural, functional, and hemodynamic assessment. So structural features, if there is already pre-existing right ventricular hypertrophy, suggestive of long-standing pulmonary hypertension, I would then move on to functional features, so the RV function, so the systolic and diastolic function, so a TAPSE less than 16 for systolic function. I would like to see whether this RV is fluid overloaded and dilated with a typical feature of what we call a D-shaped RV, causing ventricular interdependence and bowing out into the left ventricle. And then finally...
I should keep going, finally.
I would repeat an assessment of the RVSP.
Good. So let's say, it's an evolving emergency situation. You literally just put the transthoracic echo probe on. What's just one thing you'd notice if it was RV failure? You've mentioned a lot of points there, but you're not going to be, you won't have the time to be doing the TAPSE measurements and.
So to my eyes, if I see a large D-shaped right ventricle with ventricular interdependence, this is RV failure.
Great. So that's right. Let's say we haven't got the transthoracic, the TTE yet. What clinical features would make you suspect that this hypotension is due to RV failure? My CVP trace I could evaluate. That's like a JVP, right? The CVP is just a better JVP. So that you find that is also elevated. So you're pretty concerned about RV failure. How do you manage this?
Okay, so the principles of RV failure management, first of all, to manage any precipitating causes and correct physiology. So I would ensure normoxia, normocapnia, normothermia, and ensure I manage any sympathetic response that might be occurring at that point in time. Then moving on to the specific hemodynamic parameters for RV failure. First of all, I would like to reduce the pulmonary vascular resistance, both by pharmacological and non-pharmacological measures. Non-pharmacological measures would include reducing my PEEP, reducing my P inspiratory pressures, as well as increasing my FiO2 to 100%. Pharmacological measures can include agents such as prostacyclins, nebulized milrinone down the endotracheal tube, and nitric oxide. These are subspecialized, and I would be requesting help early on. I would support and augment RV contractility via dobutamine or milrinone. And as I start running those infusions, I need to ensure RV afterload and perfusion, RV perfusion is maintained by running a low-dose noradrenaline infusion with the second line being vasopressin. These patients must remain in sinus rhythm, so I would be applying a defib pad early on in anticipation of immediate cardioversion if they go into an arrhythmia.
You mentioned dobutamine and milrinone. How would you run that?
So I'm not familiar with milrinone. I have some familiarity with dobutamine. So it would be 250 milligrams in 100 mils, beginning my infusion at 2.5 mics per kilo per minute, which in an average 70 kilo patient would be somewhere between 3 to 4 mils an hour.
Now, in the absence of being able to get that medication in a hurry, let's say you haven't got that ready beforehand, what would you give to try to improve? You mentioned you'd use that for improved contractility. What would you use instead?
Adrenaline.
Sure. What kind of dose would you run?
So I would be starting 3 milligrams and 50 mils, and I would start this at 3 mils an hour.
Yeah, good. Now, that's good. So that seems to stabilize the situation, and you're able to get control of this. You then see this occur.
So this is an irregular, narrow, complex tachyarrhythmia. Looking at my single strip, I'm concerned for atrial fibrillation with possible rate-related ischemic changes, going at a very high rapid ventricular rate of 186 beats per minute with associated hypotension. If I haven't already called for help, I would call for additional help at this point in time. And have already got my defibrillator pads in situ, I would correct any obvious electrolyte abnormalities and make sure the patient is warm, administer magnesium, and would immediately I would immediately cardiovert this patient.
Yeah, how do you cardiovert this patient?
I would cardiovert this patient with a synchronized shock, beginning for AF at 150 joules.
Yeah, and say that shock doesn't work. What do you do?
I would repeat the shock up to 3 attempts.
3 attempts? Would you stay at 150?
No, I would increase up to 200 joules.
Okay, let's say, what is your pad placement for this?
Ideally AP, although I acknowledge that in an emergency situation and with the challenges of the presence of drapes, that I would do anterior lateral.
Great. Now, I want you to tell me, what are all your possible treatments for this rapid AF diagnosis? And what are the advantages and disadvantages of each?
Sure. So all the possible treatments can include, I would divide this into acute and long-term, and then
Let's go
pharmacological and non-pharmacological. So I'll just speak to the acute treatments at this point in time. So non-pharmacological interventions, of course, are cardioversion. The downsides of cardioversion are in the awake patient, they require a degree of sedation. There are still risks to both patient and staff with cardioversion, including for staff.
Oh, that's fine. Let's say just for patient risk. And keep going.
So with elective cardioversion, synchronized cardioversion, the issues for the patient are failure, inadvertent R-on-T phenomena, as well as myocardial stunning or depression. And in the setting of new AF, if it's been longer than 48 hours, potential embolization and subsequent stroke.
Mm-hmm.
And so moving on to pharmacological management, my agents of choice would be beta blockers, amiodarone, or digoxin, and correction of electrolytes. So just to go through those, correction of electrolytes is important, obviously, to correct the arrhythmia.
Actually, that's fine. So let's say correction of electrolytes is what you'll do. Keep the treatments.
Okay, so the treatments in this specific patient would be beta blockade. I would be very cautious, in fact, reluctant to administer beta blocker in this patient, particularly in the setting of known severe MR that would simply precipitate APO and worsen the situation. So that is an option, but would not be my first choice. The second two would be amiodarone and digoxin. Amiodarone is the drug of choice, particularly in known structural heart disease with AF. And I think he was already on amiodarone, just from remembering his STEM.
He was on metoprolol and amiodarone and digoxin.
Yeah. So he's on all three. But my preference in this patient would be to, if my cardioversion failed, would be to commence a loading dose of amiodarone followed by a 24-hour infusion. And then my other agent would be digoxin, which the downsides could include digoxin toxicity, as well as, that would be the main one I can think of at this point in time.
Yeah, good. So essentially your choice would be DC reversion first up, and if that failed, you mentioned that you do amiodarone. Is that right?
Yes. Yeah.
Yeah, fantastic. Good. That's the end of the Viva. Excellent. How do you feel?
I mean, I think my patient might have survived me.
They survived. Yeah, absolutely. Well, no, you did fantastic. That was, again, this felt like a very easy Viva as you're going through. I didn't have any major problems with it at all. And so I think you did really well. Now, so to the YouTube audience, thanks very much for watching and listening. What I'll do is we're going to pause this video here. And in the final exam course, which is on the anesthesia.thinkific site, you'll be able to follow the whole Viva with all the feedback as well. So thanks very much for watching and listening.
Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.